Thanks everyone for joining. It's very excited. First of all, a happy new year to everyone. Happy 2025. And this is our 5th year of webinar series that my friend and colleague Martin and I have the privilege to host. And this is part of the EUPSA ERNICA webinar series, and we're excited to learn about the management of caustic esophageal injuries in children, advances and controversies. And we have two great speakers and I would say colleagues and friends too with us today. We have Professor Antti Koivusalo will be our first speaker, and followed by Dr. Zafer Dokumcu. Have I butchered it too much? Is it?
No, that's okay.
It's okay. I don't speak either Finn, Suomi, or Turkish. So Antti, as I said, is a friend and a colleague who's very well known for his research and his interest in neonatal and pediatric surgery. Has been working at the Helsinki University Hospital and is a faculty member in the pediatric surgery department. Specializes in pediatric thoracic surgery, minimally invasive techniques, and neonatal surgery and airway procedures. You've got around 150, 160 publications for what I could see. And of course, we know you for your work on, as I said, various conditions, especially those ones in the chest that pertain esophageal atresia, tracheoesophageal fistula, and of course, work that you've done on, for instance, caustic injuries. You've been actively involved with the Finnish Association of Pediatric Surgeons, and of course also with EUPSA, with the European Pediatric Surgical Association. So without any further ado, Antti, really at the edge of our seat to hear about your presentation on the management of caustic injuries.
Okay, thank you. So
looks great. Yeah, now it's perfect.
Beautiful. Yes.
Okay, good. So what I present here is I already told about the incidents and the management organization, diagnostics and the practical early management, and then I have some cases, and we have both failures and successes, among those, and we keep on learning because the patient load is quite small. And my focus is on senior pediatric surgical part. I do very little work in the emergency department. I rarely see the patients when they come to the hospital. I don't take the history and so on. The younger doctors do that. Then I've put some Roman numbers from 1 to 6 in some of the topics which I think are controversial. Maybe for somebody else they are not, but anyway, what I think. Okay, you can read in books the pathophysiology and the clinical course when you take some caustic fluid like pellets or dish machine pellets. But what is important that if it's a real injury, you don't want to do anything violent to the esophagus for a time. It's better to make the diagnosis and then wait, because during the first 4 weeks after the injury, if you do dilatation or something that will upset the structure or the area where the injury is, you may cause more trouble. So be patient and feed the patient with other methods. Okay, there is what I told the incidence is low, but still the patients keep on coming, whether it's an accident, suicide, or a dare, and so on. And there's the organization which I already explained. All right, there's one algorithm. The first which I wanted to discuss, that why do we still have patients in Finland, although we try to prohibit everything remotely connected with caustic fluids, but in there we have not succeeded. Okay, the next is that everywhere you see algorithm for the treatment, and I think in general they are good adjuncts for the treatment, but in Helsinki we don't use them very much. We don't. They are necessary perhaps, but usually the surgery or the part of the surgeon is very low down there. So they are. You can see them in every conference or presentations. So I bypass algorithm this time. The third, which I wonder that if they are useful, is the classifications. You can do CT scans and classify the injury against the Japanese rule, or make an endoscopy and use the JARGAR classification, and then according to algorithm you do this and that when you find this and that. But in practical treatment, we don't, at least in Helsinki, find them very useful. If you find in endoscopies anything else than the normal finding, we think that there is a risk that the patient will get a stricture and the treatment will be complicated. About the CT scan, there is a boy who we think among our patients was very sick and very, very painful. Even an epidural in the thoracal area didn't help. And then we checked the scores. The CT score was 4, quite high, and the endoscopic classification maybe 3. And of course, he got the stricture, but in the end of the day, he did very well. We dilated him maybe 6-7 times, and now he's 100% peroral nutrition despite the stricture. But it needs no dilatation. So they don't. They are good in like predicting how the patient is doing, but we use them very rarely. Actually, we do the CTs very rarely for the pediatric patients. Okay, in Helsinki, we have very straightforward course. If there's a burn, the patient is sick, CRP high, we check if there's a perforation. No, then we treat conservatively, pain and nutrition. And if dysphagia comes later, we do the second endoscopy. We always do the first endoscopy within 34 hours. So I think this is not much different than in other hospitals. However, we do the, like many other hospitals also, we do the dilatation based on dysphagia. If the patient can't take oral feeding, we do the endoscopies and we start dilatations, but not before 4 weeks after the significant injury. And okay, we have not had patients in acute stage who had a perforation of esophagus. That has not happened. However, there are the options. You can use graining, you can use esophageal suction or do an operation, suture, but we don't have experience of acute surgery in these cases. But there is a case which we had a little failure. There was a boy of about 2 years age, and at the 8th postoperative day, when he was recovering the acute phase very well, we noticed that there's a stricture, and we put in a nasogastric tube. Then the boy was very annoyed by the nasogastric tube, so we said, let's do the gastrostomy, and we do just a little dilatation and the gastrostomy, and after 2 hours we got a perforation of the esophagus. It was partly contained perforation to the left side, so we just put the drains, and when he didn't get better, I decorticated the empyema, but never touched the esophagus. Of course, he developed a stricture. Here you can measure the length many ways, do the contrast study, like here you see the stricture, or you can measure the length of the stricture exactly with two scopes from below from the gastrostomy and one from the normal way, like in long gap esophageal atresia, and measure the length of the stricture. And then the basic treatment of the strictures after the caustic ingestion burns is, of course, dilatation. That's approved first line of treatment. Whether or not you add at some stage topical application of any agents, medicines, they may help, in my opinion. I've used them in many times, but I have no real comparison that how it goes without these agents. We have used a local application of mitomycin. Then it's possible to put triamcinolone or topical injection of cortisone, which I don't like, or then maybe try oral budesonide. They may be an adjunct to the treatment, but it's hard to say. Can we do without them? So there is another patient which had a dilatation of the caustic stenosis, and the same patient who had the perforation, but it healed quite nicely. And we had to do 34 dilatations during 3 years' time until we got the interval of half a year without dilatation, and for the time being, he does not need dilatations. Anyway, there was quite a lot of dilatations during anesthesia, and in some other hospitals they may think otherwise. However, the caretakers of the boy resisted the operations to the last. We don't use stents. The European Society of Gastroenterological Endoscopy don't recommend them as a primary treatment in these. They have quite a lot of problems. Anyway, I have used elegant papers of colleagues who have used stents, so I don't have experience, and I like to hear your experiences. Well, when to stop dilatations? We don't have any clear mark that when we stop dilatations which don't result to the release of the stenosis or stricture. But there is quite a good paper a couple of years ago by El Asmar, and when I read it, I found that we have more or less gone with their method. So dilate, and if you cannot reach 8 weeks interval between dilatations, so it means that the patient can eat 100% of the food, then we propose surgery. But it doesn't go that way. Usually the parents beg that we do some more dilatations and wait for a miracle. But anyway, more or less we do on these lines. And of course, if we have long strictures, they usually do not yield. You can dilate to the kingdom come, and then they stay. You can read this quite good paper if you're interested in Journal of Pediatric Surgery 4 years ago. So you have dilated tens of times, and a stricture does not yield. Then you have to consider reconstructive surgery, and of this I regret we don't have much experience what is connected with the caustic injuries. You can use stomach, colon, and jejunum, and every graft, if we call it that, have their good sides and bad sides. We use in Helsinki the one in the middle, the jejunum pedicled or free jejunum interposition, and we are happy with that. But usually in the most authoritative books or papers, they prefer gastric pull-up, which is a quite bad picture on the right. But usually the stomach, of course, it heals well. It has a good blood supply, only one anastomosis. I think that choose the technique which is best for the patient and best for the surgical team. And then, of course, if the stomach is injured, you can't maybe use it in these cases. All of the grafts has some bad things in long term, but usually they are not that bad that you can doom the grafts on those marks. Well, should you resect a stricture, a small length of esophagus, say 4 centimeters, and suture them back? Well, we have tried that once, and it went well about 2 weeks. We resected about 4 centimeters in the lower part of the esophagus after 100 dilatations, which was way too much. And we ended up anastomosing 2 ends of esophagus, which for me looked perfectly well. Beautiful, a beautiful anastomosis and a beautiful healing about 5 weeks. And after 6 weeks, again, the same thing. There was a stricture and we had to do something else. So maybe, I don't know, but I suspect that there may be something in the deep structures of the esophagus after a deep burn. It's fibrotic and the microcirculation is deficient, and maybe that will affect that. Resection is rarely mentioned in the surgery if it's needed in a long term or in deep burns. We use the jejunum interposition. It has been criticized that you can't reach the pharynx, or and it's difficult, but actually it is not. And you can improve the circulation by doing a micro anastomosis in the part which is closer to the pharynx. Take with you somebody who can take vascular micro anastomosis, and we are quite happy of this. So in this boy in whom the resection failed, we did the jejunum interposition, and it's here the X-ray, and it's working perfectly at the moment. So we regret that we didn't do it earlier. Then there's another patient who took a big amount of caustic fluid on purpose, on a suicide purpose, in a bout of I think it was like, I don't know what's called nowadays. Maybe it's bipolar psychosis. And she remained in psychosis. And then after perforation, they lost the esophagus. Only she had a cervical esophagostomy. So we chose to make the jejunum, pedicle jejunum interposition, and the patient was still in full psychosis. And we consulted the psychiatrist, and part of our team was against, but in the end we do it even if the patient was on heavy medication. And even in this, the psychiatrist recommended that we do the operation anyway. And we did it, and in this case the jejunum is placed in the substernal position. So the sternotomy is here and the jejunum about to be sewn in place here. And it went perfectly. There was 0 postoperative dilatations, and the patient recovered for the bipolar psychosis in a very short time, and is nowadays a working member of the society. There is her esophagus 1 year after the operation. You will notice that when you look in the gastroscope and do a reverse, the cardia of the esophagus, of the stomach is no more. There are no more lower esophageal sphincter or something like that. But she had reflux problems only some months, and after that we gave some months PPI, and nowadays no reflux medication. So maybe she don't tell us the truth, or she can adapt the situation. What about follow-up? I don't really know, and that's why there is a controversy 6 in the follow-up. Why follow up the patients? we have the routine that we follow up all the patients who had esophageal reconstruction. How about the rest of those? Do they have, for example, a risk for cancer? We don't really know. A recent Chinese study found that those who have taken detergents or corrosive fluids had surprisingly no increased risk of squamous epithelial cancer of esophagus. Some other authors have said that there is a certain risk. If you have a stenosis, you may develop cancer at the early age, at your 50s. And there are even more pessimistic prognostics by other authors. So we, considering the uncertainty of the cancer issue, we recommend that we do some kind of endoscopic check in adulthood, but we don't have the structure because the patients are not so numerous. Many of those patients complain GIR symptoms afterwards, but in none of them I've had a positive result in pH metry or impedance, and endoscopy, it was like unequivocal. So PPI is a good treatment, and maybe no more is needed. The more long-term troubles I have not seen in children, like fistula, stenosis, death, or brain abscess, which have been reported. So there is references. I can send it to someone if someone wants to check them. They are available in PubMed all. Thank you for your attention. That was Helsinki experience.
Thank you very much, Antti. That was very nice overview, very nice talk, and the references can be then seen also on the YouTube channel when we publish the edited video. So before we go into the discussion, I want to introduce our second speaker, which is our dear friend, Professor Zafer Dokumcu from Izmir, Turkey. He's an international well-known surgeon, underwent his training at the University, Edge University, Izmir, Turkey, and he is actively involved in both national and international societies. Like, he serves on a lot of executive boards, including the IPAC Middle East chapter. He is on the executive board of the ASPAS, and he is the chairman of the education office of the EUPSA. He's a regular mentor and faculty member on a lot of those courses organized by IPAC, EUPSA, ASPAS, and TEPS. Professor Dokumcu has a lot of academic contributions, like he is a lot of an author out of numerous international articles and published groundbreaking first series like a single incision laparoscopic pull-up and robotic esophagectomy and gastric pull-up in children. Clinically, Zafer specializes in pediatric thoracic surgery, MIS, single incision surgery, robotic surgery, neonatal and airway surgery. Zafer, it's a great honor for us to have you also tonight with us, and we are curious to hear the Izmir experience.
And what I will be talking about is the EGE experience. Is it possible me to share it?
You share, I don't know if, okay, yes.
Is it okay? Yeah, right. I think it's okay.
Perfect. Yes. You can put it on presentation mode. Amazing. Thank you.
Yeah. Well, of course, this is an EGE experience, and EGE University, the Department of Pediatric Surgery was the first one to be established in Turkey, and we have quite a huge history about the thoracic surgery division, which was funded by Professor Mutaf in 1976. So it's nearly 50 years of experience, and I'm happy to, and also privileged to be standing on the shoulders of my giant professors. While our two Olympus gods moderators have led us to these questions, and I will try to answer all these questions briefly. But like everyone, there are different points to be considered. Not every patients are the same. There are patient-related and injury-related and also treatment-related differences. This makes the standardization and the algorithms make harder because not every patient is the same. So it's quite difficult. And there are lots of treatments that superlap, overlap, and so it's not very easy to discriminate the efficacy of the treatments. Hello. Well, the injury may happen any place. Generally, we see that at the sternum notch, as you all know, with the physiological narrowing of the esophagus. So, and what a pity, we cannot know how deep is the injury occurred. And as other burns, the injury at first days does not stay like that. It may go well, or it may go deeper according to the situation of the patient, according to the agent, and also according to the endoscopy or any other intervention. So the injury may be linear or circumferential, maybe just in a little segment or in a long segment. So that these differences makes us to decide different solutions for different occasions. First, the role of esophagoscopy is quite important, and there is a controversy about doing doing endoscopy in every patient or not, etc. Well, in our experience, we do it in every suspected patients, because to keep a child without oral feeding is a huge morbidity, and it should not be done without any real reason. So you can actually classify the caustic injury in the early phase, but we have not really studied to classify the strictures. Actually, we call it simple and complex strictures, but like the patients and the injuries, strictures are also not the same. It can be soft and fibrotic, circumferential, or like web-like strictures. So, and we are trying to cure them with only one hammer in our hand, with the dilatations. So that's where the quarrels about other interventions might be needed comes. Well, in our department, this is our algorithm first to start with. So in the early admission, in the patients who admitted before the 48 hours, we have them endoscopy all. The ones who we don't really recommend endoscopy is the ones that we are sure that it's not any corrosive effect. And according to the damage, we can start the oral feedings early or maybe after 72 hours. In the last years, we don't really have to do any gastrostomies anymore like we did it in the past. But of course, hydration, analgesics are the very crucial things that you should do. In the long term, after the acute phase, if we suspect a burn, we do not go further distally in the esophagus, and we call the patients in 3-4 weeks in the outpatient clinic. And that's what we do for the late comers also after the 48 hours. And we have them, their dysphagia scores or any other complaints, and we make the decision of the esophagoscopy and the contrast study on the outpatient clinic. If we find any strictures, we have a strict protocol. It is we definitely start in the antacid medication at least 6 months or 1 year, and we started a return dilation program. The first 3 dilations is nearly 4 weeks, every 4 weeks. After the third one, we will look for the endoscopically or radiologically if it's a short segment or long segment, and we start to decide other interventions. We use the intralesional steroid injections and sometimes trichotomies in short segments. And if the patient seems to be the long segment, then we start the topical mitomycin C applications for sessions at least, and go on. Our aim, the success criterion, is the weight gain, enlarging caliber of the stricture that is recorded in every session, and also every 3 months we biopsy the esophagus, checking the gastroesophageal reflux, and we want to keep the esophagitis away from the healing wound. So if we ever suspect any gastroesophageal reflux findings and esophagitis in esophageal mucosa, even the patient is under medication, then we don't hesitate to go to anti-reflux surgery, because we know that if you cannot stop reflux, you will never stop dilatation. And if you extend, like Antti had told, if you can extend the intervals of the dilatations to 8 weeks or 3 months, then it's a good sign that this kid will clearly get off the dilation program, and we continue them. But if it's not the case, then we start to think about other esophageal stenting, resections, or replacements areas. So when you look at the literature, the esophagoscopy is really needed in every patient. Well, yes, you may not want to do it. You may do a drooling score, or you might like to do other scorings. But when you do, in nearly the 1/3 of the patients, you will not find anything. Or in another 1/3, it will be very, very mild. But there is and these patients that we like to feed and feed early and discharge early, and the other ones that you don't want to miss. So when you don't do the esophagostomy in the first stage, there is a chance that you have you can miss the major also with any problem, no complaints, but greater than grade Zargar grade 2 injuries also. What about the role of imaging? Well, in the acute phase, we always like to have the X-ray, at least for 2 purposes. One is the possibility for inhaling, and so there might be something about it, and also to see if there is any mediastinal widening or any other pathology. Happily, we don't have a very perforated case in the acute phase, but you can have an algorithm for the imagings also. We spare the CT scans for high grade or clinically not stable patients if you suspect from the perforations. And of course, the contrast studies are also done for perforations and to get the length of the strictures, is it short or wide, or if you suspect reflux, you might like to be sure about the hiatal hernia. You can also decide it from the endoscopy, but least it's critical that if you have a hiatal hernia, it means 100% reflux, which means 100% surgery. So what other medications you can do? Actually, in our hand, we don't use any systemic medications like antibiotics or corticosteroids, but I found this one from the pediatrics journal that they have done a controlled study with the high dose of metronidazole, and well, we can really conclude that you can give it. Probably the best patients who will be benefiting from it will be the Zargar 2B patients, because Zargar 2B is likely to progress for the stricture, and because it's not in the early period, it's very soft. It will be softer after 5-10 days, so it won't be a risk for perforation with prednisolone in the early phase. But these are the only patients who will benefit from. When it comes to interlesional straight injections, as I told you before, we use it quite often for short segments only. And we use it in the subcutaneously, and we are pretty sure that it really helps. You know, on the first round, it was like a bird's peak stricture. And after the steroid injections, on the bottom line, it's the appearance on the next month, after 4 weeks, the stricture starts to become softer and wider. And as much as we see the fibrotic whitish tissue on the strictures, and if it's short segment, we use them quite deliberately. And at the very right on the bottom line, you can see how it is changed from the birth peaks appearance. And we had also had the chance to publish it from our experience of the straight injections. So when you injected, the periodic dilatation index, which means the number of the dilatations in a certain period, becomes better and better. So it really helps. And this is one of the latest patients. And then there is only just 4 weeks between those two appearances, so you can see how it affects. Topical mitomycin C, we also use it in long segments. Before we decide about any replacement therapy, there's 100% that we have used topical mitomycin C before. And on the left, you can see the balloon dilatation image. And through the balloon, you can see the dilated esophageal wall. As you can see on the left, it is all white. So it's all fibrotic, and we cannot know how deep it is, but you can feel it. So these are the ones that after we dilate the esophagus, we use the topical application of mitomycin C. We use it at least 4 sessions, and we make the controls, and afterwards we go and in small number of patients who thought that these kids will require transplant replacement surgery, with topical mitomycin C, we have seen amazing results. So it's not an agent to stay away. I'm pretty happy to be using. So it's just like the one. It's total and partial responses. When you come to the stricturotomies, the stricturotomy is something that we used to be very afraid of. But after we started to do the laparoscopic esophagectomies, we started to see that the esophagus diameter is just narrowing in the lumen, but not in the out. So when you cut in the lumen, you cannot go really out of the esophageal wall very easily. So this is the hardest point. So then we have convinced ourselves that when you do the structurotomy, actually before the dilatation, actually you are deciding which side should be the tearing one. If you don't do the structurotomy and just do the balloon dilatation, the structure will decide itself where to be torn. So it may be the weakest point of the esophageal wall, and there might be slightly more chance to have a perforation. But if you go for the structurotomy with yourself, with the site that you want to be torn, I think it's much more safer, but I don't have any publication for that yet. And when we talk about esophageal stenting, we used to do that decades ago when I was a freshman resident. And actually, I have found my very, very early one of presentations of those times. And I had the chance actually to present the long-term stenting results. At the time, we used to do a handmade off-label Teflon stents with ourselves in the operating theater. Of course, it's no way that we can go like that anymore because of the ethical legal issues. And unfortunately, there are no stents like those that we used to do anymore. But I just want you to give the idea that the stenting is rational because you continuously dilate the stricture. And if you can make it there for at least 2-3 months, that's nearly successful in 2/3 of the cases. And that in that published presentation also, we have emphasized the importance of the reflux. If it's not going well, probably the problem is reflux. It's always there. So that was one of the patients that we used long-term stenting, and which was, and actually this slide, I found it in my own presentations from that time. And now recent stents are quite different. And there are metal stents, expandable ones, biodegradable ones. And as Antti told, it's scarce, very different results. Some centers are very happy about it, and also some centers have major side effects and complications. So actually, we cannot use any stenting anymore. Not yet. For the esophageal replacements, because yes, Antti is not sure about it, but there are other signs of carcinomas in some publications. So in the last 10 years, we started to do the esophagectomies when we replaced the esophagus. Also, I have found in microRNA expression changes in the burned esophagus for cancer. So I think that's a sign to be considered. I also want to emphasize that when you do the replacement, if you don't do the esophagectomy, native esophagus will always stay there. And because you did the replacement, you will not have any route, any oral or retrograde route to control, to endoscope the native esophagus anymore. So there is only MRI or CT scan changes to control the cancer. So at least in replacement patients, esophagectomy must be one of the components of the surgery. That's how we do it now. And we had also had the chance to publish the first thoracoscopic esophagectomy with the first incision, like Martin has told. That was the patient, the first one, and you see the hiatal hernia of the long stricture that pulled up the gastric. And also now we do it robot-assisted esophagectomy and gastric pull-up, and we have the chance to publish our these patients recently. And that's the algorithm again. And I hope I could answer your questions, and I will be happy to talking about the thoracoscopy workshops that we are getting ready in the end of March in Izmir. We will be announcing it in the next week. Thank you very much.
Thank you.
Thank you, Zafer, for a very nice presentation, and Antti also. And I guess we are now ready for the discussion. I see some questions in the chat. Please put all your questions in the chat, and then we can read them out loud. There is a first question of Alexander from Ukraine. What do you mean? What do you think about the Ivor-Lewis procedure, like in adult patients, like to pull up like a tubed stomach? Any experience with that? Like a
may I reply?
Well, either you or Antti, both possible. Maybe you first because your speaker is on.
Okay. About the gastric tube. That
Yes.
whether to make the of course it may work. We used to do it in esophageal atresia in the old times. However, there was an issue with the cervical anastomosis in most of them, so we changed to the full stomach pull-up, and it's much more simple if you do it only 1 or 2 a year, and usually you ended with a good result. So it may work, but if you have experience, but if not, then do the whole stomach.
Okay, great. Zafer, any comment on that?
Yeah, we have not as much as colonic or gastric pull-ups, but we have done in the previous years for gastric tubes. Also, I know from the Paris experience that it's a good option, but one thing, if the anastomosis is in the thorax, it will not be quite good because of the negative pressures, and there will be leakage. And also gastric tubes are very prone to strictures again. So there is nearly 50–60% of stricture. So we don't do it really.
Okay. Augusto?
Yeah, next question is there's Fossi Gassel. I hope I'm pronouncing that well. Asking about your opinion on the use of nasogastric tube for feeding in the acute period after the caustic injection. The same person is also asking also about the barium meal after 3–4 weeks of caustic ingestion, in case of dysphagia or only endoscopy. So nasogastric tube and then upper GI contrast study.
If it's really bad, and if we think that we will not have chance to orally feed the patient in early times, if it's Zager more than Zager 2B, you might like to think to place an NG tube or a gastrostomy, but otherwise we don't use it. And for the barium meal, we spare it for the wound to be more mature. We want to see the latest version of the stricture, actually.
Antti, do you use a nasogastric tube in the acute phase? You muted, sorry.
Oh, right. We use the nasogastric tube in the primary stage if we can pass it safely. Gastrostomies, well, then you have, in many cases, you have to do, if you can't pass it, you can do not do a peg like endoscopic peg. You have to do it open or laparoscopically. So if it seems that it takes a long time, many dilatations, then the patient may not be able to drink, but not take solid foods which has calories. So then we put the gastrostomy. We don't use the barium or any contrast that much, except when we suspect perforation or plan an operation for the patient, something else than dilatation.
Okay, thank you.
The next question is from Daya Tsugaya, I hope I pronounced that correctly, asking about the Heineken Mikulitz strictureplasty for short strictures. Any experience with that?
No.
Yeah, me neither.
My
No experience.
I tried that when I finally for a resection of the stenosis. I think from the lumen it looks really like a short stricture, but from the outside there's so much inflammation around it, so it's really hard to longitudinally incise such a stricture and then do like a strictureplasty like in a floppy bowel. So I heard of these reports, but I personally failed. But maybe somebody has experience and can put that in the chat. Next question from Vitaly Sarenda. Sorry?
I was
Any
about
comment?
to read
No.
the next one. It was about esophageal stent use. If you guys use esophageal stents.
No, I want to, but I can't because I don't think they are safe enough. And I also like to ask you, do you use esophageal stents?
There was I don't know if Antti has experience, but I think it was bad experience, at least here in Toronto in the past. Bob Filler was one of the greatest advocates for the use of esophageal stents, and unfortunately, we know that they erode and they give quite a few, some troubles to the esophagus.
But I might like to remain an open door. If I'm thinking about an esophageal replacement, I might like to use one of the stents to give the last chance, maybe. And if anything happens, I have decided to do the replacement anyway.
I think that's an excellent protocol to do everything. Also to give the parents the feeling that you tried everything to save this out. But my question is, Zafer, how long do you then leave that stent in place before you change or even remove it?
I won't be like it to stay more than 3 months, 2-3 months at most time. Well, when you think about the wound healing, the first 3 weeks is the crucial one, and then the 3rd month. So it may even be enough just to keep it for a couple of weeks, like 4, 6, 8 weeks. I think that works. That will work. But you might also end up with a very granulated and damaged esophagus also. So I cannot be really sure.
And which is the type of?
I have no experience with the new stents like the nitinols or self-expanding ones. So if Antti had used it, I don't know what he will say. But I just
I was kicked out. The question was, which type of stents are you using if you use one?
I never used one. I am just thinking about the nitinol stent so as not to have a very huge mucosal erosions and also granulation.
We have in Helsinki, we have used in other patients the ELLA stents, but they didn't solve the problem of strictures, not in the caustic strictures. And in other patients, it had it eroded into aorta and she barely survived. So, and however, the main problem is that we are not familiar with the shunts. We did a lot of endoscopies, removed foreign bodies, in small places in the bronchi, but we don't like do work with the stents like the adults do, and we don't quite like to give the patient to adult surgeons to mess with all respect.
Okay, Goncha just to the chat that they had used silicone stents in Istanbul, very helpful with long segment strictures. Yeah, you know, Goncha, I think it's an excellent point. I also think that leaving an NG tube with silicone sometimes helps because when you treat those scars in burn victims, they also get these silicone patches, and I think for some reason the silicone even in the esophagus has some effect on the scar, but I don't know. That's maybe what do you think of that hypothesis? Did you also make that experience, or is that
We
stupid?
used to do the silicone stents also, and I also sometimes use silicone stents in the airway. So I have a few experience with that. But silicones are very sticky with the food after a few weeks. So just with the impaction of the foods, you have another type of inflammation in the esophagus. So silicone does not mean that everything just goes off. So if you are even going to use it, I think it's wiser to use it in short term, like 1 month or so, not 3-6 months.
Okay, good. Then there's one question about if somebody presents very late, do you always do the contrast and the endoscopy or only endoscopy? Any thoughts on that?
Well, in Helsinki, we are very endoscopy happy, and we like to see the injury ourselves because sometimes the contrast, if you drink contrast, it goes like a mercury through, and you can't see even if there's a big trouble. But and the smaller, the more mild injuries you see readily on the endoscope. And then after some weeks, you are ready to do a therapeutic endoscopy. So that's why we use very little of the contrast.
Yeah. Okay, I don't see any other questions in the chat. May I ask you, nobody mentioned the MRI. There is a lot of data showing that the MRI might be helpful in diagnosing in the early phase the depth of the burn, and there are cases where maybe we're very near to the aorta, like in a suggestion. That's also data that the MRI helps. Nobody mentioned the MRI. Does anybody use the MRI?
Me, no. 2 reasons. Hard to get. Also, these kids are always small and you need anesthesia, etc. Endoscopy is much easier and safer.
Okay. And Zafer, can you sorry, Antti, you wanted to add something?
I agree of Chapel's opinion.
Okay, good. So Zafer, you mentioned this mitomycin C application, and Emre Divaci also has a paper with you on that. You mentioned that.
Yeah,
what is your protocol? Like, how do you place that mitomycin swab in there? Do you pull it up from the stomach, or do you pull it down through the esophagus? How do you protect the native healthy esophagus? Can you briefly share how you do it?
Well, you have dilated the stricture, and with the rigid esophagoscope, you are at the edge of the starting point of the stricture. So you can introduce mitomycin C applicated gauze on a feeding, through a feeding via the esophagoscope. Under direct vision, you just insert it in the stricture. After you are sure that that is the right place, you just push the mitomycin C through the feeding tube to the gauze. There is a gauze at the end of the feeding. Could I make
Okay, and how long do you leave the gauze in place?
5 minutes?
5 minutes. I see. Okay. Because we also tried and we were not so happy with the mitomycin C, and we also published our failures, and maybe the duration is an issue. Yeah. Good
Yeah,
point.
yeah. And you know, topical applications, you cannot be sure, but that's the way how we do it, and we are pretty happy with it.
Okay. Then from the chat, there is a question. Any experience with reversed gastric tube for esophageal replacement from Tubican? Ask that question.
I'm sorry to be, no.
But the tube, the type of gastric tube which we used was, I think it was it was called the Gavril something, Heimlich Gavring or something, that you actually don't pull you take the tube from the greater curvature of the esophagus on the gastroepiploic, right gastroepiploic artery, and then you what's called trunk, you turn it in the mediastinum and connect it with the esophagus. But like I say, if you are done many of them and you know the tricks, it can be very good, but it can also be a very clumsy tube which you are creating. But anyway, the good thing that the circulation usually is even in the tube is excellent, even in the reverse tube.
Mm-hmm. Also, there's a webinar on esophageal replacement on the YouTube channel of EUPSA and ERNICA. You might want to have a look at that also. Then Fossi Garcel is asking about any experience with bougie dilation. Well, I guess just like pneumatic dilation, and bougie is obviously cheaper.
Yeah, I didn't emphasize it. Maybe it's time to do so. In the very first dilatations, we like to do it with the bougie, because bougie gives you the feeling of the stiffness of the stricture, so you can be you can be braver, or you might like to stop if you don't feel safe. So in the early phases of the strictures, the injuries, we like to use the bougies, but after the stricture has matured, we would like to use more balloons rather than bougies, because when you insert the bougie, you strip the mucosa distally to the stomach, and that's not a good thing.
So, Zafer, listening to what you just said, that leads me to the question: when you do a pneumatic dilation with a balloon, is there any limit in millimeters that you advance? Let's say you have the 3 millimeter lumen. How far would you advance if you with a balloon dilate a stricture?
Well, it's according to the age of the patient. How much width would you expect from that? So we usually make it until 27 French in the early phases, up to 33, 36 French. So there are balloons like 9, 10, and 11, or 10, 11, 12 millimeters. That's nearly 36 French. So we generally use those.
Wow. So you're not concerned if you advance too fast, you rupture the esophagus, because there's data that you should maybe only advance 3 to 4 millimeters at a time and not go beyond that?
No, with the bougies, we do the same, really. So if you are, as I told you, if you start with bougie, you get to know the feeling of the stricture, the character of the stricture, then you can make a plan further on. But if you don't know anything about the stricture and you just insert the balloon, some complications may arise.
Mm-hmm. Thank you. Antti, any thoughts on that?
Yeah, we use only the pneumatic balloons, and well, it's about to be careful that start after 4 weeks, and if it's like a pinpoint stricture, that it's difficult to put the guide wire or the instrument through, then we start if it's let's say it's a 5-year-old boy or patient, we start with very small dilatation, 6 to 8 millimeters, and then if it's 4 weeks after the trauma, we haven't had in that way no perforations with that.
Yeah, thank you. One other question from Mahmoud Marais. What about double hit injuries, esophagus and pylorus? Do you have one of these patients with a even gastric outlet obstruction then, obviously?
We used to see those high acidic agents with high acidic agents. Actually, there are some quite strong agents for especially the factories or cleaning, etc., that might cause some trouble. Those kids are first managed with interventional radiology if they can just dilate it, and if not, then surgery might need it. That's how we do it in our center.
Mm-hmm. Then there's a contribution from Cape Town. Dr. Omar Kamak is contributing. They do a sucralfate scan with technetium labeled things to given orally, and then they can distinguish about the depth of that, so they can better grade the severity of the stricture. Anyone else doing this? I've never even heard of that, which doesn't matter. So, but maybe it's a good thing. Any experience?
So I don't know, it's interesting.
Maybe you can, Omar, can you maybe share in the chat, is there a paper on that we can read up on that? Sounds very interesting. I bet you need a very good nuclear radiology department for that. Okay, he will share the paper. Thanks. And then Dr. Ahmad is asking, any experience with the esoperistaltic gastric tube transposition? Well, I guess that was the gastric tube, which we discussed already. And then tubularized gastric patch interposition. Wow, this is really advanced surgery. So taking out part of the stomach and then patch the esophagus. Anybody experienced with this? I wonder how the blood supply, I mean, you need the gastroepiploic artery to travel then with that patch. I can picture this will be quite technically challenging. Okay, and then there's a question about pyloric dilation if you do a gastric pull-up. You know, there's the...
We used to do it routinely after gastric pull-ups. But after nearly 30 patients, we saw that when you do the routine pyloroplasty with the gastric pull-up, you have more than 30% dumping syndrome. If you don't do the pyloroplasty, you know that there will just 10-15% need of pyloric dilatation. So you don't have to do the pyloroplasty at the first place. You just do the gastric pull-up and see how it is going. If it needs, you can dilate it later. Or if you want to do the pyloroplasty, you can do it later.
Okay, good.
In Helsinki, we don't touch the pylorus, but I've used sometimes the Botox on pylorus endoscopically, and that helps a couple of months at the time.
Interesting, yeah. Okay, I see no other questions in the chat. I think then I can close the session. Professor Zani had to leave because he had some local obligations at the hospital that were very important for him. So also on behalf of Augusto Zani and Gaia, who's organizing beautifully all these webinars, I thank all the speakers. Thank you, Antti. Thank you, Zafer. And all the audience. We had like over 150 participants tonight. We will now edit the video and then place it on our YouTube channel. You can follow us on YouTube, therefore. And the next webinar will be announced on social media by Gaia. Thank you, everybody, and have a great night. Bye-bye.